brain stimulation. So first we'll just talk a little bit about where DBS falls into the treatment spectrum and why we're thinking about doing or recommending deep brain stimulation to some patients with Parkinson's. And then we'll talk a little bit about the specific sort of procedures and reasons that we kind of do the things that we do at our center in order to really optimize care for patients with Parkinson's. Okay, tell me if you're having trouble hearing me. Is that better? Okay. Say something? Something. That's what my kids do. All right, so first and foremost, just Joan talked to you and gave you a little overview about why it's so important to have a team for your Parkinson's care. Part of the challenge of Parkinson's disease is that it changes over time, and I think this is why we need so many different specialists and need to have so many different approaches, because symptoms may be different and treatments then need to be tailored according to whatever issues are going on with that individual patient. So this is just kind of kind of broad summary of what happens with Parkinson's disease. When patients are first diagnosed, we call that maybe kind of an early stage because symptoms are relatively mild. You can treat them with medications and patients usually feel pretty well. They may almost feel like they don't have Parkinson's at all. They are able to do everything that they typically always have been doing. But then as time goes on, the level of control of symptoms changes. Patients may need more medications in order to maintain adequate control of their motor symptoms. And then when they start these medications, they can start experiencing those things that we call fluctuations, which is where the medicines kick in and wear off, and you have to take multiple doses of medications per day. And then as it even sort of advances beyond that, we have to use combinations of medications in order to keep people as functional as they would like to be. Manage the dyskinesias that can happen, which are the involuntary excessive movements that come from chronic use of these medications. And then even despite all of this, Parkinson's will continue to progress and there will be other symptoms that can happen, such as cognitive changes, more impairment in balance, walking, things like that, which are harder to treat and manage with medications alone. And so then we need to really think about using a lot of ancillary therapies like physical therapy, occupational therapy, speech therapy. Really, that's something that we should be doing all along anyway, but they become even more important when we are in sort of the more advancing stages and have to manage all of these different symptoms together. So in that context, right, as time goes on with Parkinson's disease, patients are generally requiring more and more medications, and it's not unusual that people might end up on 5, 6, 7 different types of medications to manage all of these different issues. So I mentioned a couple of these concepts before. The motor fluctuations are that on and off feeling, right? So off is when patients have a relatively poor degree of overall function. Usually that's a time when more Parkinson's symptoms are present. So maybe things like tremor, stiffness, slowness, difficulty with walking, muscle tightening. And that usually happens when dopamine levels are low in the system. When patients feel on, that's usually a time when medications have kicked in and the dopamine levels are relatively higher, and patients usually describe a overall sort of relative time of good overall function and good mobility, but a lot of times this comes with other good things as well. Mood tends to be better, their cognitive functions tend to be better, and so there's a lot of not only motor symptoms that can change in this way, but also non-motor symptoms that can as well. And this sort of may be more subtle at the beginning, or it may not be as problematic, but as Parkinson's progresses, the degree of on-off fluctuation can become more intense. Patients can be more and more disabled by the constant kind of cycle of medication kicking in and wearing off, kicking in and wearing off. The other major complication that we talk about in Parkinson's disease treatment is dyskinesia, and that's these sort of slow, writhing, involuntary movements that tend to occur when the levodopa or dopamine levels are higher in the brain. They can happen at other times, but this tends to be the one where they are most, like at the peak dose of medication is when we generally see them. And sometimes they can kind of be there for a little bit and go away, and it may not be a big deal, but then as time goes on, even the dyskinesias can become more intense, and for some patients, they can happen, as soon as the medications kick in, they've got dyskinesias, and until those medications wear off, the dyskinesias are there, and the dyskinesias for some individuals can become just as problematic as the underlying Parkinson's symptoms, like tremor, stiffness, slowness. And so this becomes a challenge as well that we have to try to manage over time with Parkinson's. Now, there are certain risk factors for developing dyskinesias that we are increasingly understanding more about. Generally, patients who have a younger age of disease onset are more prone to dyskinesias. Those individuals who are taking higher doses of levodopa commonly will be more likely to develop dyskinesias. The patients have already started feeling like the medications are kicking in and wearing off. When we start making adjustments to medication, there may be a greater risk of developing it. And then people with lower body weight or female gender, also there have been several studies now that show that these individuals may be more likely to develop dyskinesia. So we have to think about these things as we're approaching sort of the care of our patients and sort of manage the medications accordingly. So when we're treating with meds, and again, Joan, I think was giving you a good overview of this, the treatment is geared at improving function and maintaining functional independence and quality of life. There really isn't they're symptomatic treatments, they're not curative treatments, and it's important to recognize that. But by the same token, they're very important to being able to live and function well and be independent. So I think, a lot of individuals have sort of a fear perhaps of taking more medication, but sometimes that really is the best way to be able to do all the other things that we want you to do, which is to exercise and live well and eat well and sleep well. So it's not necessarily realistic to be able to proceed through Parkinson's disease without appropriate medication. Joan already mentioned that levodopa is the gold standard. It's been around since the 1960s. During my career anyway, we've come full circle with levodopa. First, it was the only thing we had, then we had a lot more other stuff that we thought was better, and then now we're back to sort of preferring the levodopa just because we know the effects can be so robust. And I think the other thing to remember is that there isn't any single way to treat Parkinson's disease. It's different for different people, either what's needed or what might work. And so we really have this idea about shared decision-making and individualizing therapy for patients, for each patient that we're seeing. So of course we want to manage symptoms. We want people to be able to function well, and that means functioning well in any of the different things that you want to do. So if you're still working, obviously there are things associated with that. If there are certain hobbies that you'd like to engage in, we want you to be able to continue that. If there's leisure activities that you would like to partake in and find difficult because of your Parkinson's symptoms, we obviously want to have that in mind as well. And maintaining a good medication regimen along with other healthy lifestyle things that we won't get into really so much right now is really important to maintaining quality of life. We want to address the non-motor features, which are a whole host of other medications that won't be necessarily things that we get into today. And as I mentioned before, these are symptomatic treatments. So if their symptoms are present, then we can treat them with the medications, but we're not necessarily modifying the disease progression or curing disease. So this is just a summary slide of a lot of the different medication options that are available. It ranges all the way from levodopa to dopamine agonists to meds that help the levodopa work better, medications that have particular functions in Parkinson's disease, different ways of administering all of these different medications. So the great news is that we have all of these different options, and I think it's great to see a lot of the companies here represented that are offering these. But that's the good news. I think we have to just be smart about how we use these medications, and that's sort of the conversation that we need to have with your doctor about which meds are appropriate and how to adjust them. So exercise, diet, and supplements are also certainly important to healthy living. Studies are increasingly showing beneficial effects of a regular exercise regimen. It doesn't have to be anything super intense. Just getting up and moving, even if it's a walk for 15, 20 minutes a day, is better than not doing that. So whatever it is that you can manage in terms of your day and in terms of your level of functioning is certainly something that we want to be able to support. People often ask about diet, and we don't have a particular diet to recommend. I think what is important is healthy diet, because we don't want other medical issues necessarily to become more problematic and complicate the treatment of the Parkinson's disease. There are some concerns about how medications work in relationship to protein, and those are issues that may be relevant to some people, but not all necessarily. And then we may want to consider some particular dietary modifications when patients are specifically bothered by things like constipation. And a lot of supplements are kind of out there, and you have to be careful, I think, of what you read about and what you try, not so much because they are harmful, some of them may be, and so we have to be thoughtful of that, but the supplements that are out there are probably, they're not likely to give you the same benefit as Parkinson's medications. They may add something to kind of the overall health or other disease issues that might be going on, but supplements really don't have, as far as we know yet, evidence of really changing the course of Parkinson's or treating symptoms in a way that's very different from the kind of classic Parkinson's medication. So I don't want to discourage the use of supplements. I just want to be realistic about what we really think it might be able to do. So moving on then from that, right, that's the framework in which we start with Parkinson's disease treatment, is this medication management, healthy living, etc. When we get to a point that these things are maybe not helping symptoms as well as we would like, there are surgical therapies that we can consider. And we're going to focus on deep brain stimulation. There are others, as Joan was mentioning, the focus ultrasound and the Pwp pumps. We won't talk about those today. We'll talk specifically about deep brain stimulation, because that's the program that I am the medical director of, and Joan is a huge part of that program. This is generally reserved for patients who have developed those complications. Okay, so there's a whole sort of subjectivity to when is the right time to thinking about doing deep brain stimulation, but fundamentally, we're generally thinking about it when patients are experiencing those fluctuations and those dyskinesias, and we're having trouble managing them with just medications. And it's really been shown through multiple studies over the years, and we've had deep brain stimulation now for 3 decades, that it significantly improves motor functioning in patients with Parkinson's, but then also can improve quality of life compared to just continuing to manage with medications. So this is an implanted electrode that delivers high-frequency electrical stimulation to the structures in the brain that are involved in the control of movement. And these 3 sort of medical terms that I have here are the locations within the brain that we can locate the stimulation. And what it does is we know when we record the brain activity in each of these different locations that there's something irregular about the firing patterns of those neurons. And if we can go in there and apply a little bit of electricity to those areas, then we can kind of put the brain back into a normal state of functioning, or a more normal state of functioning, I should say. And when that happens, that's when we're able to improve the symptoms of Parkinson's disease. And DBS is not something that you want to necessarily be signing up for when meds are working quite appropriately, and so it's not the early sort of thing that we would recommend, but it's also not the last resort. Okay, so that's one thing that I want to emphasize as well. There's certainly a time and a window of opportunity that is ideal for deep brain stimulation. If we go too early, then we might be exposing patients to risk. If we wait too long, then we might be losing an opportunity to really help and get the maximum benefits out of deep brain stimulation. So we really want to make sure that we are thinking about that and implementing it when it's most likely to be helpful. So generally, we're talking about patients who have a diagnosis of regular Parkinson's disease with a good response to levodopa, but where that response is limited by having the wearing off effects or having dyskinesias. Or sometimes we'll do this surgery also when patients are having a lot of tremor that isn't well controlled with medications. We're often thinking about surgery when there are not significant issues with thinking, memory, mood, behavior. However, having said that, sometimes those are things that need to be better regulated. And if we're able to regulate those, then we can still consider DBS. Or if we think that there's really some substantial quality of life benefits to be had from controlling those motor symptoms better, we may still consider surgery in patients who have some of these underlying problems. It's generally something that we don't have a specific age cutoff for. I will say most of the patients that we operate on are under 70, but that doesn't mean that we don't operate on patients who are older, so that's not an absolute criteria. But we do also need to consider whether or not there are other conditions that would make surgery, per se, too risky for a patient from a medical standpoint. So thinking about DBS, what makes DBS successful is when we pick the right patient, when we pick the right part of the brain to stimulate, when we get that electrode in properly and safely, when we program the DBS system ideally and optimally, and when we have that very clear expectation of what an individual patient might be able to expect from an outcome from that surgery. The last thing we want to do is to suggest that some specific issue or some specific problem that a patient has is definitely going to be helped by the surgery, and then down the road find out that that really wasn't the case. And we also want to make sure that patients are in a supportive environment and are able to get to all of their appointments and be able to sort of adjust to all the changes that are going to be happening over time with DBS. So it's important for patients and families to have reasonable expectations. It's really clear that DBS does not give greater benefit than medications alone. It does treat symptoms that will improve with the Parkinson's medication. So if you are dealing with symptoms that kind of come and go because of those on and off fluctuations, you have to think about that best on time that you have with medication and imagine what is the day going to be like if I'm like that all day long. Okay? And those are the symptoms that we generally advise are going to be better. DBS is used in combination with medication. It's not a replacement for medication. So we don't promise that people will be able to come off medications after DBS. What we promise is better control of motor symptoms. So it's used in combination with those medications, often with a reduction in the amount of those medications. It's also not a cure. Okay? So this will not stop Parkinson's in its tracks. We will be able to get a better handle on symptoms, but there are then certain things that may continue to progress over time, just like Parkinson's does. And there may be parts of those things that are adjustable or, kind of, again, managed by adjusting the deep brain stimulation. And there are certain of those things that are not going to be treatable with the DBS adjustment. But we do know, again, that DBS improves probability of quality. So the reasonable things that we would expect are that it will reduce or eliminate dyskinesias. It will reduce or eliminate the off times that patients are experiencing, reduce or eliminate the tremor, rigidity, or the bradykinesia, that slowness of movement, again, to the extent that medications do. It tends to improve walking, but not necessarily balance, especially if meds help the walking. If there are still significant problems with walking when meds are working, you won't get better benefit in that from the deep brain stimulator. It does reduce medication dependence, but not necessarily get rid of medications, as I mentioned. And as I also alluded to already, DBS does not prevent the disease from getting worse. Cognitive problems, for example, may still develop. Patients may still continue to experience loss of abilities as the disease progresses in other ways. So this is kind of like a graphic to help you understand sort of what we're talking about here. So if you think about that optimal sort of on time where things are pretty good, before surgery, that may be hard to sort of stay in that range of just good function, because if you don't take your meds, you're off. If you take too much medication, you'll be dyskinetic. And so DBS just sort of brings things back to the middle and keeps it stable for most of the day. So just a couple of clarifications. DBS does not work better than levodopa. It does not fix problems that levodopa doesn't address, except for tremor. That's the only exception. It doesn't cure Parkinson's. I said that for the third time. It doesn't slow or stop progression of the disease. Some of the non-motor symptoms may improve, but not all of them. And issues like speech, swallowing, gait freezing, balance problems, those are things that we're going to have a harder time even with deep brain stimulation. So this is how we evaluate patients at Mount Sinai for deep brain stimulation. The first step would be if you are having a conversation with your neurologist about your Parkinson's symptoms, and it becomes apparent that you're having these characteristics, the fluctuations, the dyskinesias, or maybe the tremor that isn't well controlled. You will talk to your doctor about that, and you may choose to initiate the process of preoperative testing. This is not the kind of surgery that you go into just saying, oh, yep, I'm having these problems. When you go see the surgeon, I'll see when I have the device in place. You go through a whole evaluation process, neurology testing, neuropsychology testing, psychiatry testing, and psychology testing. We're actually pretty unique in the region for offering all of these evaluations. We have a lot of interest in trying to treat as much of the Parkinson's as we can, and a lot of the Parkinson's is motor symptoms, but there's also a lot that comes from the non-motor symptoms, and that's why we have this excellent neuropsychology, psychiatry, psychology team that helps us in assessing the comprehensive sort of issues with patients, and we try to target as many of those features and symptoms as we can. And after all of these evaluations are complete, we actually get together in a team meeting and talk about each individual case at a consensus meeting. So everybody has their information to provide about what they have gathered and learned about the patient, and we will carefully discuss whether we think DDS is a good option for the patient, and if it is a good option, where in the brain we want to put that stimulator to try to get the best results for that patient. And that goes back to that slide that had the different locations that we can stimulate. So I think what I would sort of highlight about our program at Mount Sinai is just how individualized our treatment approach is. We use this testing that we do to really help guide patient expectations and outcomes after DDS, so there's no surprises. Why did this not get better? Why did that get better? Or why am I having this problem? We want to make sure that DDS really does have some benefit to offer the individual. Unfortunately, we do still see this on patients that come to us asking for help with their DDS devices that they weren't getting the results that they had expected. And we want, to have a better understanding of the patient's baseline thinking skills, their emotional state, their behavior, and try to have these addressed either before the surgery or during the course of the DDS therapy. So again, patients are getting the maximum benefit. You'll hear more about this from and this team of experts. Again, this multidisciplinary team. This multidisciplinary team approach, as I mentioned, is pretty unique in the area. So we're fortunate to be able to offer that, and I think we've been seeing some really good results as a consequence of being able to address all different aspects. Okay, there are risks of surgery. You need to feel comfortable with those. I'm not going to go through all of these, but there are surgical risks. And then there are other things that can happen during the post-operative programming. I'm sorry, I think this is an old slide, so I apologize. It's not 100% correct, but there is a whole programming phase. Once you get the surgery done, then there's a whole phase of getting the brain stimulator to work for you. So that is what the programming process is. I'm going to just click forward. Oops. I'm not going to move forward. But there's a whole series of programming appointments that have to happen in order to rebalance a patient after DDS. So we're providing a stimulation. It allows us to reduce the medication, but we can't just go in and do that all in one go because there can be complications of doing that too quickly, both of ramping up the stimulation too fast or of reducing the medications too quickly. So we kind of do it bit by bit and month by month. Often it takes about 6 months to get patients fully re-optimized after the stimulator is placed. But that gradual process, I promise, is well worth the effort at the end because we get much better control of Parkinson's symptoms when really, as I said before, medications weren't doing it. Once we get patients optimized on their new stimulation and their new schedule of medications, then we kind of just continue to follow patients like we would any other Parkinson's patient every 3 or 4 months in clinic, checking in on all the other stuff that we do. It's just one other thing that we have to factor in to the overall care of the patient once this process is done. I just want to highlight our team. Joan did a great job of emphasizing how important it is to have a team. Our deep brain stimulation team is actually quite large. We have a number of different neurologists at our center, shown in the top row there, who are at our west location, at our downtown location, and also at our Upper East Side location. So we have tremendous access for patients who are interested in this therapy. We generally lead a team of nurse practitioners who also are active participants in both the evaluation and the management of patients with DDS. Our neurosurgical team, we have 2 surgeons and their nurse practitioners. And then at the bottom there is our neuropsychiatry, psychiatry, and behavioral health team that is involved. So everybody kind of gets seen by everyone, not all of these people, but one of each. But anyway, well represented in our multidisciplinary team with ongoing follow-up. So I'm going to stop there. Thank you for your attention. Yeah. So next we have Dr. Shannon O'Neill, who's on our behavioral health team. She's a psychologist. Dr. Shannon O'Neill, who is who's on our behavioral health team and who is a psychologist. So she performs on our DDS team a pretty comprehensive and I think unique assessment of patients that goes beyond the traditional neuropsychology testing, which you might see at other places. But I think she has, over the years, developed some very important insights that she brings from her training into how we can approach mental health needs and behavioral therapy in patients with Parkinson's who are undergoing this procedure. So as soon as she sees that, we will have her presentation as well.
All right, thank you, Dr. Shahid. I'm trying to share my screen, but it's disabled. Is someone able to give me access to that?
Hold on, Shannon, we can't see her.
Oh, there we go, great. All right, let's see here. How's my volume? Everyone hear me okay?
Yeah.
Okay, wonderful. You know, I so apologize I can't be there. Feeling a little under the weather, but I thought that this was a very important discussion to have, and I'd love to advertise our team at Mount Sinai. I thought in an effort to make lemons into lemonade, I'm showcasing my office behind me. I'm at Mount Sinai West right now. And this is a good example of what a telehealth appointment looks like. So that's what we'll consider this today. So as Dr. Shahid had mentioned, I am a psychologist on the team for the Center for Neuromodulation at Mount Sinai West, and we treat a range of conditions, both movement disorder and psychiatric conditions. Of course, today we will be focusing on Parkinson's within the context of behavioral medicine, or I'm sorry, within the context of deep brain stimulation. So my objectives for today are to highlight the importance of mental health within the context of DBS, discuss my role as a psychologist on the team, and then I want to go through some experiential exercises that are often applied or implemented with patients pre-surgically, intraoperatively, and post-operatively. This is not to say, I want to really emphasize that the experiential exercises we do are not just for someone who has Parkinson's, are not just for someone who's going through a medical workup, but this can be done in everyday life, which is why I want to highlight them today. I think they're very beneficial tools that can be important in quality of life in general. So as we have said across today, I want to highlight what is unique about Mount Sinai. When engaging in a DBS workup, a typical team consists of the following. So across other hospitals, you might be, of course, naturally consulting with a neurologist, a neurosurgeon, and then neuropsychology, just to assess cognitive functioning and any risks for cognitive decline post-surgery. And what sets Mount Sinai apart is that we also have psychiatry on the team, which is Dr. Fagui and myself, the psychologist. Why this might be important is that we can appreciate you are so much more than your motor symptoms, and in fact, so much more than all your symptoms, even non-motor. There's a whole host of variables across your life that Parkinson's is impacting, and we want to acknowledge that, and this can be very complementary to mental health services that I offer. And it's not a one and done evaluation as well. That's another thing that I think is really important for our team, is that we're not just doing a pre-surgical workup, but we're along your team. We're part of your team every step of the way. So before I begin discussing my role, I wanted to define it a little bit more clearly. Behavioral medicine, in the most simple terms, is It entails promoting behavioral modification to manage stress of a physical diagnosis or a procedure. And just like traditional medicine, how it can assist with physical health, let's say your carbidopa levodopa, a multivitamin, even a sleep aid, these medicines can assist with physical health. There are aspects of behavioral medicine that can help with mental health. Keeping with this analogy, though, what I think is very important is just like you don't take your carbidopa levodopa anytime you remember to take it, let's say every Wednesday when it comes to your mind, it's not going to be effective when you take it every now and then. Similarly, behavioral medicine isn't effective if you just apply it here and there. It is important to almost treat it like a daily dose, just like your other medications that you're taking. Okay, so I want to jump into pre-operative services. They can be broken down into 3 sections: a behavioral medicine evaluation, individual psychotherapy, and pre-DBS surgical prep group that I'll explain in a little bit. So trying to identify the impact of Parkinson's on psychosocial variables, this can offer a really nice baseline snapshot to monitor change across following the implantation of the device. I look for specific variables such as your social support, your current coping strategies, any mood fluctuations you have, pre-existing mood disorders, a whole host of things, really looking more closely into the individual. And one of my favorite aspects of this evaluation is examining your expectations for surgery. So I often start by saying, let's imagine the device has been implanted, programming has been optimized, it's in great working condition, you're going about living your life, and now you can do what? What can you do in your day-to-day that you can nod to the device and say, wow, I'm really satisfied I did this surgery? Some people might say, I'll be able to, rather than just saying, I want my tremor to reduce or I want to reduce my medications, I ask them to go a little deeper. And so they might say, I want to type with 2 hands, or I want to drink with a cup without having to use a straw. These are really functional goals that we can take a look at post DBS and see how they're doing. Also, with individual psychotherapy, there might be some expectations that we need to manage across the patient and the family, focused on any substance use that needs to be reduced, organizing their medication and adherence to their medication and their appointments, and of course, any anticipatory anxiety leading up to neurosurgery. The neurosurgeon's nurse practitioner, her name is Meredith, and I co-facilitate a pre-surgical DBS group, and we focus on giving as much information as possible. Within one of my assessments in the behavioral medicine evaluation, I look at not just, there's a lot of questionnaires that individuals are receiving, and sometimes it's all about the pathology or it's all about the negative things that we need to focus on. What I love about one of the assessments that I implement or that I administer to individuals is that it's a strength-based measure. And one thing that has been really highlighted across Parkinson's patients is that the majority of you are really eager for information. And this domain is called information receptivity. So you want to be as informed as possible about the surgery that you're investing in, and you want to feel well equipped. So this was this is why this group was created, to highlight all the logistics of when to stop medicine before surgery, what shampoo to purchase, all of the nitty-gritty of what it takes to get to the surgery day. And then I showcase some behavioral medicine strategies that help just manage the stress of it all, because it's a very long journey and we want you to feel as equipped as possible. That leads to the first experiential exercise that I want to focus on, which is grounding. And of course, as I said, the surgical process can feel rather overwhelming, and it leads to anticipatory anxiety. This is very natural. So anxiety, when I talk with individuals, when I talk with patients, I'll often mention anxiety typically lives in the future. And when your thoughts are depressed, it's usually focused on the past. So if your mind is wandering to the future, and it typically can be related to a lot of rumination, a lot of what if content, And it's hard to stay focused in the present moment, focused on the task at hand, fulfilling the responsibilities in the moment. So grounding can be a really helpful tool to slow down your thought process, be in the present moment, and identify all the things that you can bring into the room where the present moment is, which is where the only place we have certainty lies. So if you want to do this silently to yourself, I want to highlight bringing in things in your environment that allow you to ground to the present moment. So we start with 5 things you can see. So you're in a room right now, surrounded by a lot of other individuals. If you can take a look around and identify 5 things you can see. For example, in my room right now, I can see my office phone. I can see a computer mouse. I'm trying to bring in other aspects of the environment that I might be looking over. Then you're focused on 4 things you can feel. All of a sudden, I can feel the heaviness of my right foot on the floor compared to my left. This might be something just completely unconscious in your mind, but all of a sudden you're tapping into it and you can feel it more vividly. 3 things you can hear. I can hear the hospital speaker going off with information. I can hear my fan going. Maybe you can hear the sound of my voice. 2 things you can smell. Keep in mind what's really interesting, and I've done this so many times with individuals with Parkinson's groups, and they've been so gracious in reminding me, wait a minute, sometimes we have a muted sense of smell. Then what? One thing that can be really helpful to identify is just tapping into a reminder of an image of a smell you've had in the past. So can you access in your mind the smell of freshly ground coffee, or cinnamon rolls, or something that was a pleasant dessert that you used to bake as a child? Being able to access memories of smell can also be just as helpful if you can't smell as strongly in the present moment. And then one thing you can taste. Similar on the topic of grounding, sometimes people will put a mint in their mouth, chew a piece of gum, focus on the physical sensation of that mint in their mouth. If you're not currently don't have access to anything to taste, I often say one thing that you are grateful for in this moment. So I want to, that is one experiential exercise. I really do want to emphasize that this takes daily practice, and I don't want to minimize the importance of distraction. So in that moment of doing 5, 4, 3, 2, 1 grounding, your mind wasn't in the future thinking about your surgery coming up, but it was at least tapped into a pleasant distraction of accessing other things in your mind. I use this standing in line at a grocery store, commuting on a train, when it feels as though I'm waiting for a long period of time and I just want to tap into grounding myself when I'm maybe anticipating just wanting to get to the next thing. This can be very helpful for me. Okay, intraoperative. I'm going to go into the intraoperative services. 2 particularly important aspects of my services during the intraoperative phase are, of course, helping someone get through the awake portion of surgery and then the overnight hospital stay. So the awake portion is often a feature of DBS that naturally produces anxiety. And it would be very odd if you weren't anxious related to this process. Within the awake portion, this is when the neurosurgeon will test the stimulator's impact on your motor symptoms. It's really important to highlight that some people remember this quite vividly, others don't remember it at all. But the important feature is you won't feel any pain during it. Regardless, being able to ground yourself to other imagery and access a safe place in your mind can be helpful to get through this awake portion. And we're actually going to go through an experiential exercise called safe space imagery. And then the overnight hospital stay, whether it be sharing a room with another individual, pain management, missing your family, wanting the comfort of your own home, all of these can be reasons for having a little bit of challenge during your overnight stay. And so it's important to note that all of this is emphasized during the pre-surgical prep group, ways to make sure that you're equipped going into the hospital and what tools and techniques to recommend getting through that overnight stay. One thing that's often interesting when I get feedback from patients is that they come well equipped, they're ready to go, they have their movies downloaded, they have Sudoku, and they emphasize that they just slept until they were discharged. So it didn't need any of the tools, but they were happy they had them. So let's go into an experiential exercise called the safe space imagery. This is an attempt to strive to create a really relaxing image in your mind, which allows your mind and your body to relax. This can allow for an emotional timeout, and it can be for during very high periods of stress. So I'm going to read this script. It's about 5 minutes. And if you feel comfortable closing your eyes, please feel free to do so. If it's easier for you to just stare at a fixed point on the ground, something that isn't as distracting for you as you listen to my voice here. So this is safe place imagery. We'll start by sitting comfortably, breathing and relaxing, trusting that your imagination will do the work for you, and feel yourself supported by the chair or the floor, and allow your eyes to come closed. Allow your attention to move to your breathing, letting your breathing become even and comfortable. Now I'd like you to imagine yourself in a very special place. It could be a real place, a place you may actually have been, a beautiful spot in nature, or a comforting place in your own home. You may know the place well or have never seen it before. Your special place may be an imaginary place, a place in fairy tales, indoors or outdoors. It doesn't matter. Should more than one place come to mind, allow yourself to stay with one of them. The only thing that matters is that this is a place in which you feel comfortable, you feel completely safe. Begin to appreciate this scene with all your senses, hearing the sounds, smelling the aromas, and feeling the air as it caresses your skin. Touch and feel the whole environment that you're in. Notice what you're wearing. If you have anything on your feet, notice the time of year and the time of day. Become aware of the temperature of the air on your skin. Is it warm or cool? And notice how old you are. Notice if you're alone or if someone else is there. And look around you to notice if there is anything else that would make this place more comfortable for you. Perhaps something you need to remove from the place or something you would like to bring in. If you would like to bring someone or something else into this space, do it now. Breathing deeply and enjoying the feelings of relaxation and comfort. And now thank yourself for taking the time. Perhaps promising yourself and reassuring yourself that you will visit this place or some other place in your own whenever you need to. Know that you can return to this place anytime you wish to relax and be replenished. Just by doing exactly as you are doing now. sitting in a comfortable position, allowing your eyes to come closed, and bringing the image of your special place. But for now, begin to gently come back to the room, becoming aware of yourself, sitting, breathing deeply, connecting to the space, and slowly opening your eyes. All right. That is called the safe place or safe imagery. Hopefully with practice over time, being able to have something very vivid come to your mind, you can tap into so easily with all your senses to travel to that place if you need to during the awake portion, during the overnight hospital stay, again, while waiting in a grocery line. It could be anywhere. Having this safe space imagery is very important. I have asked individuals in the past of what image came to their mind. Someone said, I love the question that says, what age are you? Because I think that that's really important. There's a lot of other ages in our lives that were much more simple than they are now. And one individual said he basically painted a Norman Rockwell photo of himself on a tricycle with the porch light on, going down an empty childhood block. So it was a very simple time in his life and something that gave him a lot of comfort. Okay.
It's Susan.
Yeah.
Hi. Shannon and I did some radio shows together, and I've only met her in this capacity over Zoom, and I was so hoping to meet her in person today, but I think these exercises are terrific. And I just, before you go on, I think that a lot of people, when they do these exercises, they think, it's not for me, what do I need it for? I just want you, while we're here, and just having done that exercise, just to address that, why really this is so important.
Oh, I mean, great question. I mean, I think that, when people often say that in session, I've certainly heard that a time or two before, individuals will assume that they tried it once and it wasn't for them. That kind of reminds me of the assumption that you do one bicep rep and you do like you're doing lifting in the gym and you do one single curl and you're like, oh, didn't work. I didn't get biceps, so it's not for me. To be able to practice and really tap into it can be very helpful. You might be surprised what comes to your mind as you continue to practice. But also, I mean, that's a fair statement. And there's so many guided imagery exercises. There's so many different interventions that this is such a simple appetizer of interventions that I'm highlighting today, that there's so much more that could be for them. So keep searching for the one that fits for them and then latching onto it. I know a lot of individuals that way. Once they find their technique, it's their go-to, and it just takes some trial and error. That's okay, just being open to it. That was a great question. I will go into the final stage, which is the post-operative stage. Another exciting time, and as Dr. Shahad has said before, sometimes individuals think that they are done, like they have completed DBS, they are done with DBS, but in fact, this is actually when their journey just starts, is when they are starting with the programming and they're going about living their life. So similar to how I broke down the services pre-surgically, it's the very same workup: behavioral medicine evaluation, individual psychotherapy, and a post-DBS group. When you get to the behavioral medicine evaluation post-DBS, this is 6 months after your first programming session. So from start to finish of when I meet you pre-surgically to post-DBS, it's been a good year. And so I like to say that we're going to open up this time capsule. I'm going to look at my report pre-surgically, and we're going to look at your functional goals. So I will say within the pre-surgical evaluation, you mentioned you wanted to drink a cup of water without using a straw. Has this been met for you? And so we're exploring beyond tremor reduction, medication reduction, improvement in dyskinesia. We're trying to tap into functionally, how will you be satisfied with surgery? What do you want to get back into your life? And oftentimes it's the simple things. I want to complete a task before my medication wears off. And so they feel so much more regulated with stimulation and they can follow through with tasks easier. There's a list of things that might pop up that would qualify for individual psychotherapy. Exploring psychosocial adjustment. This can be quite a life-changing surgery, and to explore how this is impacting even the role, the dynamics within the family and different roles and responsibilities individuals now have. That is something to explore and discuss, whether it be individually or amongst a family session. Developing value-oriented goals. This will be our final experiential exercise that I want to focus on. And then the post-DBS programming process. Just like pre-surgical prep group, you're automatically enrolled into this group. And so after your first programming, you'll be scheduled out for 6 monthly sessions that you're amongst all these other peers who are going through programming at the same time. And we're focused on areas of not just specific to, we're not talking about dyskinesia and tremor within the group. We're talking about so much more of just quality of life and values that you're getting back into as your self-image starts to change. So I will go into the final experiential exercise, which is developing a SMART goal. What we know about SMART goals, or what we know about the surgery, is that walking can be a very helpful goal post DBS to assist with the programming and to assist with the recovery process itself. However, individuals often stop with the goal by saying, I want to walk more. That's usually a goal that people want to end the session with and say, okay, I'm going to go walk more this week. But what makes something so much more helpful and promotes much more confidence in being able to execute this goal is making it as specific as possible. And so if we start with, this acronym stands for specific, measurable, attainable, relevant, and time-based. So if we start with the specifics, we could say, okay, I want to increase my daily step count. How will we make this measurable? Maybe we'll say, okay, I'll measure it by wearing a step counter, but I will also do 10,000 steps a day. Perfect timing for, is this really attainable? Okay, maybe not 10,000 steps. I haven't walked 10,000 steps in 10 years. How about I start post-DBS with 2,500 steps? I will also make this attainable by making sure I have new shoes with traction. I'll charge my watch that counts my steps for me. Why is this relevant? We know that it assists with recovery. It also offers an opportunity to test out improved motor functioning, see if things are working for you. And then time-based, when will this be done? I'll start my daily step counts in the morning right after breakfast. I'll walk the block. So you can see the difference between a goal of, I'm going to walk more, versus I'm going to increase my daily step count to 2,500 steps with a step counter, and in order to assist with recovery, and I'll start it off after breakfast. That makes it very detailed, helps with executing the goal very specifically. Okay, so I want to leave you with this quote. My hope today is that I really illustrated the importance of mental health within DBS. And I really believe our team, I think Joan and Dr. Shaw had both illustrated it as well. We stand by this statement. We truly are striving to take into consideration the whole person, and we can appreciate that we are treating you and your unique set of circumstances, not just your motor symptoms. All right, thank you.